Alright, so now we're going to be doing a lot of this mycology stuff. Mycology is not exactly the longest section. Bacteria was definitely very, very long. Mycology is pretty small. I should actually be able to finish all of it in one sitting, so I'm going to go ahead and try to do that right now. I'm about to message people right now, letting them know that I'm live. So if you don't have the notifications turned on for whenever I do go live, then you won't know. But yeah, I mean, I have a little group of Facebook pages. I have a Facebook page, but I have a group of Facebook messages where I let people know I'm live, just in case. You know, I don't know why they don't turn on YouTube notifications, but it's okay. I can still let them know. And I posted on the Facebook USMLE Step 1 page. Here we go. Okay, so mycology. There's a bunch of medications, right? People that do sketchy farm, they're gonna have a different experience. For me, it was just sketchy micro, and I only really incorporate the sketchy micro stuff. So sketchy micro obviously fortunately does a good job letting you know what medications to use for all of these bugs, and that's honestly good enough for me. Sketchy farm is more important for all the other things like cancer medications and medications for their other organ systems. So I've never really used sketchy farm, although I've seen like 2 or 3 other videos, and I felt like for me personally it was just sketchy farm was adding too many visuals into my mind. It was already a lot of visuals you have to know with all the sketchy micro on top of visuals you already need to know from first aid itself. So it was getting a little excessive for me personally. We finished all the bacteria already, right? And we saw for every bug, we understood the background of the image would tell you gram-positive or negative, and then the presence of certain things would tell you what medication to use, right? 3-axis was ceftriaxones. Anyone holding a rifle was for rifampin. We saw flowers or fluoroquinolones and stuff like that was really perfect for memorizing what medication would be good for a group of people. Now here we're going to see antifungal medication. So on the top I've kind of summarized the 4 general classes, right? Number 1 are polyenes, amphotericin B and nystatin. Those are your 2 polyenes. They bind to ergosterol molecules in the fungal cell membrane, creating pores and causing cell lysis. And they depend on ergosterol. So if there's a fungi that doesn't have ergosterol, you can't use those medications on them. Triazoles, or your ketoconazole, fluconazole, itraconazole, all those azole medications, they inhibit the synthesis of ergosterol. So once again, if it's a fungi that doesn't need ergosterol, that won't work on them either. Echinocandins, like caspofungin, inhibit the synthesis of glucan in the fungal cell wall. So this is what you would use against those that don't have ergosterol. Right? And then the pyrimidines, like flucytosine. Right? Flucytosine is the only agent in this class of antifungals that's converted to 5-fluorouracil within the fungal cell wall, and within the fungal cell, and interferes with fungal RNA and protein synthesis, thereby eventually killing them off. So the presence of ergosterol, the presence of glucan, those are definitely big deals. And then where you would use flucytosine, and we're going to see the medications you would use. The first thing we have here are your systemic mycoses, right? So all of the following can cause pneumonia and can disseminate. So already we just added a shit ton of stuff to our pneumonia microbiology questions, right? So you can get a question on microbiology totally regarding pneumonia, and every single bug, you're going to have like 10 answer choices there. Every single possible bug that causes pneumonia will be there, and some of these will be there. Right? All are caused by dimorphic fungi, right? So they have different presentations depending on the temperature. So in the cold, at 20 degrees Celsius, they are mold, whereas in hotter temperatures, at 37 degrees, they make yeast, or they become yeast. The only exception is coccidioids, which is a spheruole, not a yeast, in tissue. And we're going to see that as well. Systemic mycoses can form granulomas like TB, but they cannot be transmitted person to person. Right? And the only other time we saw no person-to-person transmission was in Legionella pneumonia. That did not have person-to-person transmission either. Treatment is with fluconazole or itraconazole for local infections, and then you have to use amphotericin B for systemic infections. All right. For amphotericin B, in all images from here on, whenever you need amphotericin B for treatment, the sketchy micro image is going to have a frog or a bunch of frogs in the picture. Right, so we're going to see all the sketchy micro images at the bottom, but let's discuss these guys first. Right, so we have our histoplasmosis, blastomycosis, coccidioid, and paracoccidioid. Histoplasmosis, histo hides in macrophages, right? That's the number one statement you have to remember. Histo hides in macrophages. They're really tiny, and they are inside macrophages, within macrophages. They're found endemically in the Mississippi and Ohio River Valley areas. So this map is kind of showing you what that region is. Right? The most likely region, the highest prominence of these guys is in the Mississippi and Ohio River Valley areas. And the pathology feature is that macrophage filled with histoplasma, which is smaller than red blood cells, right? There's a comparison to red blood cells at all times. Histo is smaller than red blood cells. Blastomycosis is generally the same size as red blood cells, and coccidioids, right, much larger than red blood cells. All right, so they do go in that order, HBC. And what does histo cause? So histo causes palatal and tongue ulcers, right? This is a pretty rare thing to have ulcers on the palate or tongue. So if you do hear that, histo should ring a bell. And of course, splenomegaly and pancytopenia are the other things, but those are pretty non-specific, right? So palatal and tongue ulcers are all we're really seeing from histoplasmosis. And remember, they all already cause pneumonia and disseminate. So pneumonia is a given for all of these guys, all four of them. But along with the pneumonia, you're going to have palatal and tongue ulcers, right? You should see a question related to bird or bat droppings, right? So there is overlap with the bird and bat stuff because bats are found in caves, and that can come up. But look for questions regarding a person who manages birds, right? Bird coops and stuff like that, because this is related to bird or bat droppings. So this is someone who's really been around for quite a while with their poop. And diagnosis is just by finding the antigen in their urine or in their serum, right? Because you can't really see the bug itself. They're all inside macrophages. The immune response resembles that induced by tuberculosis, right? Because just like tuberculosis is also within macrophages, so is histoplasmosis. So you're going to have your cellular response with the formation of granuloma. Fungus targets histiocytes and the RES, reticular endothelial system. Right, so that's just little information that'll be in questions, but we're going to do a couple questions. I think they're on the last page. Yeah, right here. I have a bunch of questions. When we finish all the bugs, we'll go into some URL questions. So that's histo right there. Then you have blastomycosis, and you see this picture of blasto, the way that this is budding, right? This is known as broad-based budding. And the broad base that they're talking about is this point where they connect, right? It's broad. So when they're budding, there's two ways to bud. You can become really, really thin and then bud, or you can stay really thick and then bud. And this stays thick, right? So there's a pretty big area in between where they're still connected. The stalk is thick. That stalk between the two cells is still thick. And that's what they mean by broad-based budding, as opposed to a very, very thin stalk and then the cells separate. So those are two different types of budding that you would have. Blasto is pretty common, mostly, generally speaking, the entire eastern side of the United States, right? So eastern and central U.S., Great Lakes. All of this eastern map is pretty much covered. So the question obviously won't have anything to do with California, right, or any of Nevada, any of these states that are on that side. Now, if your U.S. geography isn't exactly that good, if you don't know the location of the states and stuff like that, it doesn't really hurt to open up a map of the United States and just look at it, see where the states kind of look like they are. Even as an American, I can't really necessarily point out every single state on this map. I don't know where they all are, but I do have a general understanding of which ones are western and which ones are central and which ones are eastern. So that's what you really want to grab, if anything. Now, blasto, right? Blasto buds broadly. That's the sentence for blasto. But what does it cause? On top of pneumonia, it causes inflammatory lung disease, can disseminate to the skin and bone. So it can cause verrucous skin lesions that simulate small cell carcinoma, right? You can see this looks a lot like what we saw earlier when we were looking at the skin cancer stuff. So let me show you that real quick. Let me go back all the way to, I think it was within DNA pyrimidine repairs. Yeah. Right, so right here we're seeing, sorry, not small cell carcinoma, squamous cell carcinoma, right? So this thing that happened to this person's nose right here, for example, is one example of that, right? The skin one is squamous cell carcinoma, not small. So squamous cell carcinoma is what this kind of makes it look like on the person's skin, but it won't be squamous cell carcinoma at all. No, I don't think I'll be doing sketchy form at all. I don't think so, because I never really did it, so I'm not going to really invest time in doing sketchy form. Obviously, that's definitely something that if you're interested in doing, you should go ahead and buy and give it a shot. But my goal right now is to finish up this entire book, right? Get through all the systems as fast as I can through this month, and then start moving into CK. So that's what I'm trying to work on right now. And then, of course, if anyone is interested in buying the book, they can go ahead and send me an email, and I'll send you a copy of the book. But other than that, I'm just finishing this up because I'm done with all the annotations, anything I needed to fix up, and I'm done adding questions from like Amboss and UWorld and stuff. So yeah, I'm just making one final video with all the perfect corrected notes, no mistakes, to the best of my abilities, and then gonna try to move into CK videos after this now. Alright, so compared to histo, which just caused ulcers on the palate and tongue, blasto has skin dissemination, right? You're seeing all this stuff on the skin and bone as well. You're gonna know symptoms on the bone as well. Pulmonary pneumonia can self-resolve and will have granuloma formation, right? And then over here, what we're seeing is the granulomatous nodules. Alright, that's what we're looking at right here on the liver. Alright, so same size as red blood cells. So that takes care of blasto. Now the last one is coccidioid. Coccidioid mycoses. Southwestern US and California. So you can see blasto and coccidioid don't really have much overlap. So they do kind of go in, completely different regions. Histo would be very much towards the central area, just the Mississippi and Ohio River valleys really. Mississippi and Ohio. Blasto is pretty much all of eastern. Coccidioid is this area of the southwest. So the western half. There's no overlap between blasto and coccidioid. So coccidioid, much bigger than a red blood cell. You're going to see that in the peripheral smears you get, right? And this also disseminates to skin and bone, just like blasto. So one big difference between blasto and coccidioid will be where the person was when they got sick, right? What state they were in. It also causes erythema nodosum, right? Erythema nodosum, which is a desert bump or multiforme, erythema multiforme. So this over here, this image is showing the erythema nodosum. Okay, this is the one showing you all the desert bumps that they get. So you can see this young child that just has like ripped up skin all over them as if they've been like whipped or something, right? Arthralgias, which is just known as desert rheumatism, and it can cause meningitis. Alright, so if you have a question about one of these guys, the only one of these four that causes meningitis is coccidioid. Associated with dust exposure or endemic areas like excavations or earthquakes, right? So you really want to think of the desert aspect of things a lot, right? A lot of dust, a lot of sand floating around. Is that liver pic on blasto? Yes, this one. Let me actually find the pic with the notes too. I do need to move that over. Mycology. Okay. What was the note on this? Yeah, blastomycosis. This gross view of the lung shows more clearly the areas of necrosis, which are labeled, this one right here, number 1. Satellite lesions are also present, which are 2 and 3. Alright, so let me copy this over, because what happened is when you do, there's a feature known as file print as, and then you can print as PDF. That takes all pictures that are in the book and makes them part of the book. That's kind of what I do to sell the book, but I stopped doing it because after I did it the first time, I realized that the pictures have notes, and those notes disappear once the picture becomes part of the book. So that's fixed. But yes, this liver image is a thing for blasto, and the reason I put this here is you could tell this blue background and everything. This is literally kind of very similar to the way NBME and UWorld tend to show random pictures, right? Gross pictures. So this would happen, right? You're gonna get a picture about a liver with satellite lesions, and they'll be like, which one of these bugs caused it? But as you could tell, the book didn't really talk about liver injury at all, right? But they disseminate. All of these guys disseminate. They can go anywhere. Right, so don't let that throw you off. So this is just showing you a gross image of oh sorry, not even the liver, it's the lung, my bad. Gross view of the lung shows more clearly the areas of the necrosis, which is this one right here. Let me make it big for you guys now. It was very easy to confuse this to be the liver, obviously from the color, but this is not a physiological image, so you can't really work with the color alone. Right, it's the lung. Okay, so blastomycosis. This gross view of the lung shows more clearly the areas of necrosis, which are labeled number 1, right here. So it's all black, and consolidation, which is number 2, the white areas, and satellite lesions are also present, which are the tiny ones that you can see in different spots. All right, so that's your lung right there, and that makes sense now because as I was saying it, I was thinking, wait a minute, but although it disseminates, like, how would you even think of that for step 1, like the liver? So blastomycosis, definitely all of these guys affect the lung. And here, this image, this thing is pretty specific to blasto. I haven't seen any question like this with like lung lesions. I keep saying liver, lung lesions of one of these other guys. Alright, so that was the lung right there. Blasto. Satellite lesions and consolidation in the lung. Alright. So this is why I have this note right here. So pulmonary pneumonia can self-resolve, but you're going to have granuloma formation, granulomatous nodules, right? These granulomatous nodules they're talking about, that was what was being pointed out by number 3 right there. The tiny nodules all over. Alright, so 3 different guys, 3 different things, right? We saw histo, hides in macrophages, causes tongue and palate ulcers. We saw blasto, same size as red blood cells, and has broad-based budding, and it disseminates the skin and causes the squamous cell carcinoma type of lesion on skin, and granulomatous nodules. And then coccidioid, which is much bigger than a red blood cell, also disseminates the skin, but it also causes these weird, you could describe it as a rash, but really just a lot of lesions all over the skin and arthralgias, as well as particularly meningitis. Right, so now the last one, paracoccidioids. This usually needs you to be, like, they'll pretty much have to tell you either a picture or a description of how paracoccidioid looks, because it doesn't cause anything specific that would help you identify it, right? The only real identification it has is its shape. Right. Other than that, like Latin America, sure. So Latin America would be like down here, the countries that are below. So Puerto Rico, Mexico, stuff like that. Similar to blastomycosis. So again, palatal and tongue ulcers. But other than that, you really can't identify anything else for it. So let's start looking at sketchy microimages now, right? So first thing we had was histo, right? And these pictures are just showing you, like this one up here shows you an ulcer in the palate. This one shows you ulcers in the tongue. So histoplasmosis, that would be, I believe this image, yeah. Okay, so this is the histoplasmosis image, the historian's cave. When you hear histo, think historian. Think of the man as Indiana Jones, Indiana Jones' nerdy stepbrother. Indiana Jones is really popular from the movie, right? But this is not Indiana Jones, this is his nerdy stepbrother. And histo is actually prevalent in Indiana, which is one of the states along that same region. On exams, histo will be associated with bird or bad droppings, but examiners may instead tell you that someone was inside a cave or was exposed to chicken coops while farming. They won't necessarily tell you that this person was playing with birds or playing with bats, right? So that's the secret way or low-key way that they'll try to get you to understand that this question has nothing to do with birds or bats. Histo is endemic to the midwestern and central USA along the Mississippi and Ohio River valleys, hence the map that the historian is looking at, which is right down here. Pretty much the same exact map that's given in the other image I put up there. And now in the 2019 book, they have a big map in the center. I'll show you guys after this. The historian is coughing because transmission is via inhalation, where the histo goes to the lungs and are ingested by macrophages. So diagnosis is by finding macrophages with small bodies inside, depicted by the cage with the canary, right? So the cage has always been macrophages, right? So that's the cage with the canary showing you histo hides in macrophages. A better diagnostic test is the rapid urine or serum antigen test, depicted by the two types of drips on the right. Right, so the drips they're talking about are these two drips up here, the red one and the yellow one, right? There's stuff dripping from them. So those are your diagnostic tests: serum antigen test, or you could check in blood as well, right? So blood is the red for blood and the yellow for urine. You could either check blood or check urine. And if you look at the bottom over here in the drips, it looks like there's a big cell with things inside, right? So that's what you're seeing, basically, macrophages with things inside. And that part's not so hard to remember. So the puddles depict what a macrophage will look like when full of histoplasma, which is much smaller than a red blood cell. Obviously, since there are several histo in one macrophage, and a macrophage is slightly bigger than a red blood cell, right? So you do have to remember the sizes, because that's going to be one major distinction between all of them. Histoplasma is dimorphic, so its form is dependent on the temperature around it. And this feature is shared among the systemic mycoses, depicted by the butterfly, right? A butterfly, every time you see the butterfly, even later on, tells you that it's dimorphic. And that's a nice image to use, because butterflies start as a caterpillar and then they have wings, right? So they do change, they morph. All of them are dimorphic except coccidioid, right? Because it's spherical. So don't forget that one, though. We're not going to see a butterfly in that image. Right, so depicted by the butterfly: mold in the cold and yeast in the heat. The butterfly is initially a caterpillar and undergoes metamorphosis, so this is a good sign. Clinical presentation is generally asymptomatic or subclinical in most people. However, it can cause granuloma formation in some people's lungs, which then calcify and lead to chronic pulmonary issues due to calcified nodules with fibrotic scarring that resembles TB, demonstrated by the stones on the wall with the big, long, dark crack acting as the mediastinum, right? So what's happening is these two things are supposed to be your lungs, right? And then the space in between is your mediastinum, and you can see the white lesions that are on it. Those are your calcifications. That's what you're seeing there, right? And you can see the cracks are showing you the lobes, right? 2 lobes on the left lung, 3 lobes on the right lung. So that's pretty evident there. The 2 pillars. Oh, and then there's the other 2 pillars. The stone on the left has 3 lobes, and the stone on the right has 2 lobes, with spiky stone growing out to remind you calcifications. In addition, the book has the cacti from TB, right? And that would be these books right here. Remember in the tuberculosis image, we had the cactus there, and in the cactus, you got to see that initially infection would be at the lower lobes, because when you breathe things in, it does go to the lower lobes. But then reactivation is usually at the upper lobes, because there's a lot of oxygen up there, right? And Mycoplasma pneumoniae likes the oxygen that's up there. So that's what the cactuses in that image was showing you. The 2 pillars have red dots to remind you of erythema nodosum. Painful nodules usually found on the shins, so they resemble legs with knees, and that's what these 2 pillars are supposed to remind you of. Erythema nodosum, another thing that histoplasma can cause. The yellow pillar that represents urine antigen test is now in perfect position to represent the penis, which kind of just was a little joke they said worked out, right? Because it's in between the 2 legs. So all of that falls into place, really helps you further remember. And you can see the bats up here as well, right? Bats flying around. Dissemination can lead to hepatosplenomegaly in immunocompromised patients, hence the cow painting with the liver and spleen shots, right? So you can see that liver and spleen spots, right? So this cow, just like earlier in the micro area, in the bacteria area, anytime you see a cow with spots on it, it tells you where you're going to have splenomegaly or hepatomegaly. The gross pathology will show calcification in the liver and spleen. The fungus targets the reticular endothelial system, which has a lot of macrophages, which are prevalent in the liver and spleen. The cane by the historian is for immunocompromised as usual. Treatment is with azoles for local infection like fluconazole or ketoconazole, depicted by the pine cones. all pine cones in any image are to remind you of azole medications. So these pine cones that are right here, right? And for systemic infections, you always have to use amphotericin B for all systemic infections. So here, instead of having real frogs, there's a painting of a frog. Okay, so we got to hear some new information here that wasn't mentioned by the book, right? The calcification of things. So if you get a question where there's mention of one of these 4 bugs, and then the spleen or the liver has calcification happening at random areas, you should really think of histoplasmosis at that point, right? And definitely look for someone that's traveling in a cave, because they're going to be exposed to bad droppings, or someone that was in an area where they have just a lot of pigeon poop all around, right? Maybe they're cleaning up or something. And that's generally it for histoplasmosis. So this is the map that they put into the book now, which is pretty much just a combination of all 3, right? So the green is the histoplasmosis area, which has a lot of overlap with the blastomycosis area, right? And then the only one that doesn't have overlap is coccidioidal mycosis. So this one, I believe, is the next one, which would be your blastomycosis. Let's make the picture bigger. Oh, this is coccidioids. Okay, so this image is for coccidioids, right? And oh, okay, yeah, I remember now. All right, so this is called Presidio San Joaquin. The name of this image didn't really help remember anything, but you're gonna see why this is the scene they chose. So the scene takes place in a presidio, which is a Spanish military settlement, and presidio rhymes with coccidio. So that's what they were trying to do with that name, right? But if you don't know, if you've never heard of the word presidio, it's not really gonna stick to you per se. Presidios are common in California and southwestern USA, which is the distribution of cocci, further reinforced by the map under the statue highlighting the southwest. As you can see that right here. Transmission is by inhalation of spores and dust, which can occur in San Joaquin dust storms, especially after earthquakes, which are common in California. This is depicted by the cracks in the ground and wall as if there was a recent earthquake. The butterfly on the top right is to depict the dimorphic nature, but here it is a mold in the cold, and it is a spherule of endospores in the heat, not yeast, right? So it's still dimorphic. It is still dimorphic, but it's a different kind of dimorphology. The endospores then spread throughout the lungs and possibly the body, demonstrated by the tumbleweeds that resemble spherules that you'd see in blood smears. The spherules are larger than red blood cells, depicted by the red sombrero blowing in the wind and resembling an RBC. Right? You can see this red sombrero is tiny compared to the spherule around. Right? So we got the earthquake, we got all the dust floating, we understand that aspect. And we understand that it's much bigger than a red blood cell. Symptoms are asymptomatic or subclinical in most patients, but can present with acute pneumonia with fever, sweats, and arthralgias that can last for a few weeks, depicted by the soldier coughing, sweating, and hitting his knee on the ground. That's this guy right here. Right? And the yellow symbols are really making it clear that he fell pretty hard on his knee. The crack on the wall acts like a mediastinum, and the 2 sides of the crack mimic lungs. So once again, similar kind of way of showing you the lungs again. Radiographic images may show nothing or cavities and nodules depicted by the bricks. Cocci can also present with erythema nodosum, an inflammatory condition with painful red nodules that is also seen in histo. The pillars on the left resemble shins, and they have red dots. So once again, these 2 pillars over here, very similar to the pillars we saw in histo, are showing you the red dots again, right? So we see symptomatic overlap between the 2, but the maps don't overlap at all. So erythema nodosum in both histo and coccidioid. Erythema nodosum represents a robust immune response, so this is seen in immunocompetent patients. In immunocompromised patients, depicted by the statue of Junipero with his cane. So this statue is a statue of this guy named Junipero Serra, a Roman Catholic priest and missionary. He has a cane, and there are cracks and lesions on his skin and lungs because those are common sites of infection. His left leg has a black rod exposed for osteomyelitis. Very important to remember, right? Osteomyelitis, because coccidioid had dissemination to the bone as well. The fungus can also affect the meninges, which was pretty unique to it compared to, in these 4, that was a pretty unique thing of it. causing meningitis, depicted by the soldier leaning on the statue with a neck brace. Right, so anyone wearing a neck brace is always meningitis, and that's something we start seeing here. We see a lot more meningitis when we get to the viruses. A potassium hydroxide stain or culture can be used for diagnosis, or you could search for IgM against cocci serology, a common theme of all systemic fungi. Treatment is with azoles for local lung infections. So again, the pine cones are here. Systemic infection requires amphotericin B, so you have your frogs over here, right? So earthquakes, dimorphic, but it's a spherical, and it's much bigger than red blood cells, causes a bunch of systemic issues, especially the arthralgias and the meningitis, right? And then the lung nodules, but you don't necessarily have to have lung nodules. Erythema nodosum, just like histo once again, and in the immunocompromised, osteomyelitis. Okay, so that was coccidioid, histococcidioid. Now right here is blastomycosis. Blastomyces dermatitis, the blast of the cannons, which is why you're supposed to remember blastomycosis compared to the other one, right? Don't forget the word that was related to coccidioid, right? It's a presidio. A presidio is a thing, and it's a very common thing in California, but it started in like Latin countries. So if you've never heard of what a presidio is, definitely spend some time looking it up, understand it. It's fun learning things that are non-medical while you're learning medicine. It definitely makes it a little less boring, if anything. So for blasto, we have the blast of the cannons, so that's pretty easy to remember. The image is during the Civil War era because its geographic distribution overlaps the location of Civil War battles, southern and eastern USA. And if you don't know about the Civil War, it's called the Civil War because it was a war within America, America fighting itself, but different parts of America. There is overlap with the distribution of histoplasmosis, but the buzzwords for blasto are the Great Lakes and Ohio River Valley. Hence, the location is a huge river valley, right? You could tell this is a river valley. It's just the water is pretty much gone now because of all the water. There is a guy holding a map in the middle depicting the shaded distribution of the eastern half of the USA, right? It always looks like either some kind of it looks like a peace sign for the most part, but it also just looks like a person that's jumping with their hands in the air. So the distribution of blasto is very unique compared to the other two. Once in the body, blasto replicates by broad-based budding, depicted by the cannonballs he's holding. They are double cannons connected to each other. Right, so you can see the cannons this guy's holding right here. They're double cannons, right? And they're all over the floor too. Double cannons. So broad-based budding, and that's the easiest thing to remember about blasto. Blasto buds broadly. Pretty easy to remember that. The size of blasto related to red blood cell is equivalent to a red blood cell. The cannons are landing on the floor in cracks that resemble lungs, right? So you can see your two lungs right here again, right in the mediastinum, and the cannons are landing in there to remind you of your the lung manifestation you're gonna have, right? So you see cannonballs and the dust depicting patchy alveolar infiltrates of the lungs. The landing site of each cannon depicts lesions or cavities that may be present on imaging, leading to pneumonia. In the immunocompromised, it can lead to systemic infection, but majority of infections are subclinical or asymptomatic. The statue of Robert E. Lee, the guy on the horse, he was a commander of the Confederate States Army during the Civil War. This statue, and you can see he's holding what we're going to assume is a cane, right? But he didn't really have a cane, but we need the cane because of immunocompromise. He has a cane for immunocompromise. He has a little bullet hole. He has little bullet hole type craters to represent disseminated skin and bone infection. His ulcerating craters on the skin and the chunk of leg missing represent the skin lesions and once again osteomyelitis. Right. Diagnosis of systemic fungi can be done by potassium hydroxide prep or culture, and you'll see round yeast with single broad-based bud. Additionally, a urine antigen test can be used too. So the river in the back is yellow, like urine, all the way back there. Local infection is treated with azoles, mainly itraconazole. So you can see pine cones on the right side by the immunocompetent soldier. Right, so all those pine cones over there. And for the immunocompromised with systemic infection, you pull out your terrible medication, amphotericin B. Right? Amphotericin B is a really bad medication in the sense that it just has so many terrible side effects. So you got to watch out for that in questions. They pop up. That's where sketchy form is used. People who want to understand how medications interact with each other and what their side effects are. But I never really found it that helpful. Like, medications are really something you learn through experience. The more you're at the hospital, the more you're working with medications, and it's a really difficult thing to learn without that experience. So it does suck that we as students have to know them before we even have the full experience, but that's just how it is. This last image here is for Paracoccidioids brasiliensis, right? So pirates of sewer, pirates, del is of, del sewer, pirates of the south. Right. The geographical distribution is in the South America depicted by the map, right? So this is South America. You can see America ended up there already. So you see South America now. The next buzzword is its appearance in yeast form, which has multiple buds radiating out from a central vacuole, depicted by the captain's wheel. There's also a mold form, so it is dimorphic, depicted by the butterfly tattoo on the pirate, right? He has that butterfly tattoo right there. The center of the wheel is red to approximate the paracoccyxia is much larger than a red blood cell, just like coccidioid. The captain is coughing, which represents symptoms as well as transmission, depicted by the large water droplets that are coming off from his cough. After inhalation of these droplets, the fungus disseminates, leading to lymphadenopathy, depicted by the white beads on his dreadlocks, right? So you have your cervical, inguinal, and axillary lymphadenopathy. Right, that's the picture right there. Okay. It progresses to affect the upper respiratory system and lungs, depicted by the big medallions on his necklace. Right, this is all the places it'll be mainly affecting lungs. The medallions should also remind you of the granulomas you'll see in the lungs. There will also be developmental of mucosal ulcers in the gums of the mouth with small spots of hemorrhage, depicted by the pirate's poor dentition, and red spots on his gums. So very similar to something we saw way in the beginning with histoplasma, but those were actual ulcers, palatal ulcers. Mucocutaneous lesions and lymphadenopathy are the most important defining features of paracoccycia. Local infections are treated with itraconazole, which again has the pine cones on the top hanging up there, and amphotericin B is used for systemic infections as usual. Right, and you can see the frog right here. And there's also a frog here. They're not green this time. Alright, so that's your 4 guides. So they're definitely very different from each other. Very different from each other. I would definitely say they're very boring to study, but questions on them are usually going to try to trick you into like showing some overlap. You have to establish the diagnosis based off of location, a history of what they were doing, whether they were near some excavation site, entering a cave or something, right, in a bird coop or something, and then of course symptoms, right? They're all going to have pneumonia, so that part doesn't really help. Then you have to look for what else they have. If they're immunocompetent, do they have the erythema nodosum, which was something you saw in coccidioid as well as in histoplasmosis, or are they immunocompromised? Because then you start seeing a lot of far worse issues, and those far worse issues are the ones that really help you identify, right? Both blasto and coccidioid had osteomyelitis involved. Histo literally just has tongue and palate ulcers and not much else to it, right? So it's not the worst thing to identify. They're not that bad. It's just you have to be careful. Don't pick blasto when it's clearly histo. Don't make that kind of confusion. They will try to confuse you with that. These 2 guys are often where people get confused when they're about to pick an answer choice. But look for everything the question is giving you and do your best to make that connection. Cutaneous mycoses are easy, right? So you have your tinea. There's a bunch of different tinnias. The dermatophytes, they're all named very well to remind you of where they cause infection. So clinical name for dermatophyte is cutaneous fungal infections. Dermatophytes include microsporum, trichophyton, and epidermophyton. 3 different guys, right? These can be answer choices. It won't always just say tinea. Branching septate hyphae visible on KOH preparation with blue fungal stain, associated with pruritus, of course. So you have your capitis, corporis, cruris for crotch, right, inguinal area, pedis, and unguium. So capitis occurs on the head and scalp, associated with lymphadenopathy, alopecia, and scaling. Really straightforward, right? You can see that in this guy right here. So A does a good job showing you what they mentioned right here, the blue fungal stain, right? KOH prep with blue fungal stain, and you can see that. And this is nice because this image won't turn out to be green or purple or whatever on your test. It will be blue. That's the only way you can see it, right? Oftentimes, a lot of different images do get changed up in color, like you can see what's happening here, right? But that won't happen. For tinea, it's always going to be blue, just like A and H are showing you. The images below were not for tinea, so we'll get there when we see them. Alright, so microsporum, trichophyton, and epidermophyton. Talked about capitis. Corporus, for your body, corpora, usually the torso, characterized by enlarging erythematous scaly rings, also just called ringworm, right? Ringworm with central clearing. And ringworm, you've definitely at some point seen someone with ringworm. The most common reason someone gets ringworm is because they don't shower enough, right? So they sweat a lot and they work hard. Either they're very, very athletic, or they just have a very difficult job where they're sweating all the time, but they don't shower enough. Maybe out of sheer laziness. Maybe they, I can't imagine what else it could be besides sheer laziness, to be honest. And then, or they don't shower correctly, right? They don't shower correctly. So you see things like this. Now this is actually really, really, really pink. It doesn't have to be that pink. It could be a very pale pink as well. This is like dark pink. It could be a very pale pink with central clearing, and that's like almost like a target lesion once again, but not big ones, really tiny, tiny target lesions. And that's what ringworm is. It literally is the size of a ring that you would wear on your finger. Can be acquired from contact with infected pets or farm animals, and that's the only other thing besides someone who doesn't shower enough and sweats a lot. Tinea cruris occurs in the inguinal area, often does not show the central clearing seen in tinea corporis. So you can see in the inguinal area it's just all pinkish, like a rash. Tinea pedis has 3 varieties. Interdigital, which is the most common, right? So between digits, interdigital. It's just a nice moist area, right? And especially between the big toe and the second toe. That's the most common area. There's a moccasin distribution, which is image F, right? So on the side, moccasin distribution, and the vesicular type. Now, how important is it to know these distributions? I don't really think it's something they'll really test you on. I've never seen a question on, but it's just more for your knowledge, if anything. Over here, I wrote, athletes are especially susceptible to tinea infections, and animals are good carriers of dermatophytes. Woods lamps are good for diagnosing microsporum. Treatment of tinea infection are topical azoles like clotrimazole. Onychomycosis, which is tinea infection of the nails, is treated with oral medications like terbinafine or griseofulvin, right? Nail fungus. Nail fungus is treated differently, and they do have topical treatment for nail fungus now, but depending on the severity, the topical treatment might not be enough. Right, so that's the last one right here. Tinea unguium. Onychomycosis occurs on nails. Right, and they didn't have a picture for that, so that's why I put it right here. Right, the nail just looks all like really, really destroyed, and that's because the fungus is kind of destroying the collagen of the nails. The last thing down here is tinea versicolor, right? Pteriasis, caused by Mycoses species like Mycoses furfur, right, or the Pterosporum species. A yeast-like fungus, not a dermatophyte, despite being called tinea. It's not a dermatophyte. Degradation of lipids produces acids that inhibit tyrosinase, involved in melanin synthesis. We saw tyrosinase way back in biochem. So that causes hypopigmentation, right? And you can see this. And this also is something you've probably seen in someone you know at some point, right? This is also going to be a similar type of thing where some person that doesn't shower enough but sweats a lot. This usually occurs in like the axillary regions, right? Or you'll see it like near their back because they don't scrub their back when they're showering. All these are very important things, and you're going to start seeing like these patchy whitish areas, right? That's tinea versicolor, and it's easy to remember because color, right? So it's all white color now. There is no color. Hyperpigmentation and/or pink patches can also occur due to an inflammatory response, less pruritic than dermatophytes. They're actually often not even slightly pruritic. They're just white patches are the way you identify it. Can occur any time of year, but more common in summer because of the hot, humid weather and all the sweating. Spaghetti and meatballs appearance on microscopy is right here. You're always going to see that. Treatment is selenium sulfide, topical and or oral antifungal medications. Right? Generally speaking, the topical stuff just takes care of it. You don't have to take anything systemic for it. Topical stuff just takes care of it. Within the week, it'll all just die out and fall off of you when you shower correctly, and that's it. Right? You may see Mycoses fungemia in neonates getting total parenteral nutrition since the fungus loves lipids. Right? So this is a weird question I had. I don't remember the question anymore, and I'm not sure why I didn't write it, or maybe I did later on. It's probably under the list of all the questions that were there. But an infant, a neonate, getting total parenteral nutrition can have tinea versicolor infection, because total parenteral infection nutrition, basically being fed through like a pipe or something, allows for a lot of lipids to just be there for the fungus to work with. Right? The fungus is in the stratum corneum, the most superficial layer of the skin, which is why topical treatment works very well for it. Alright, now these two guys are mucor and rhizopus, and they're coming up on the next page, so we'll come back to that after looking at that. But this page about tinea, very straightforward stuff, right? Treatment, just remember, topical azoles like clotrimazole are generally perfect for all of these guys. It just does the job. You don't need anything else. Taking griseofulvin and terbinafine. Terbinafine, especially, is a medication perfect for nail fungus. At first, you should do it, right? If this person just got diagnosed with nail fungus and it's really bad and their nails are all deformed, it's okay. The nails are deformed, but nail keeps growing. So the deformed part is just gonna, grow out, and you could just cut it off. And then you're supposed to start growing normal nail at some point. So terbinafine does take care of that. Has bad side effects. You got to do blood tests and stuff, liver function tests and stuff as well. And I know all this because I have a patient that, when I was doing a rotation, they did need to start taking terbinafine. It worked perfectly for that patient. By the end of that 6-week rotation, they already had major improvement, right? Because the new nail they were growing, nail grows pretty quickly, and the new nail they were growing was growing smooth rather than being all deformed and ripped up. Alright, so let's look at opportunistic fungal infection. So opportunistic basically means it's looking for people who are, compromised, right? So Candida albicans, number 1. Dimorphic, forms pseudohyphae and budding yeast at 20 degrees Celsius, but the special thing are the germ tubes that it makes at 37 degrees Celsius. Germ tubes. So pseudohyphae at 20 degrees and germ tubes at 37. Systemic or superficial fungal infection causes oral and esophageal thrush in immunocompromised neonates, steroid-using diabetic patients, AIDS patients. It can cause vulvovaginitis in diabetics or people who use antibiotics, and it can cause the typical diaper rash we see in pediatrics. It can also cause endocarditis in IV drug users, so it'll be right side related, and disseminated candidiasis, especially in neutropenic patients, as well as something known as CMC, chronic mucocutaneous candidiasis. So it causes a lot of issues, right? But a lot of it is just mucocutaneous or inflammatory. Treatment is oral fluconazole, topical azoles for the vaginal stuff, nystatin, fluconazole or echinocandins for the oral or esophageal part, and fluconazole, echinocandins, or amphotericin B for anything systemic. So basically speaking, fluconazole is in all 3 areas, so it'll take care of everything, right? Fluconazole will take care of the vaginal, the oral esophageal, and the systemic stuff. So that's the perfect medication to give. But if for some reason you cannot give fluconazoles, then you go over to echinocandins, right? Because echinocandins will take care of the oral esophageal as well as your systemic stuff. Other than that, amphotericin B, and just give them one other medication that takes care of it. So like nystatin and amphotericin B, right? And that's generally it for them. C. albicans thrush can be scraped off, as opposed to the hairy oral leukoplakia caused by Epstein-Barr virus, which is literally a sign of HIV, which cannot be scraped off, and both heavily indicate immunocompromised health. Dimorphic pseudohyphae with blastoconidia, right? Candidemia is associated with vascular catheters used for parenteral nutrition because the lipids are thought to promote candida growth. So here we see another different scenario, most likely also from UWorld, where parenteral nutrition is involved, right? So Candida, and then up here was Tinea versicolor in neonates. So let's jump down to the Candida sketchy micro image, which we have right here. Right, so the image is already pretty big. This is the Candida image. There's a lot of shit happening in it. One of the most heavily tested fungi. This is a typical Canadian town with snow to depict alba, right? Because the word alba means white. So we're in Canada now, which again, Canadian flag. So you get to know that part. Candida uses both cutaneous and systemic fungal infections. A neutropenic or immunocompromised patient or a diabetic patient with fungal infection consider Candida. It is dimorphic and forms budding yeast in the cold, and germ tube hyphae in hot temperatures. So we have the butterfly, right? So the butterfly is flying right here, so you already know it's dimorphic, but you have to remember what that dimorphic type looks like. And this does a really good job. This image has helped me memorize that a little better. So you can see the back right has a warm ice cream shop with 37 flavors, where the snow cones come with a straw depicting a germ tube true hyphae at 37 degrees. Right, so all these cones come with a straw, 37 flavors for 37 degrees Celsius, and snowballs resembling yeast cells with the thermometer showing 20 degrees Celsius. So these snowballs right here, this thermometer with 20 degrees Celsius. So what you're looking at is when you have the snowballs, there's a lot of pseudo hyphae. They're not real hyphae, right? And then when you have the warmer area with this sun image here, even though it's an ice cream, the straw is there, so you can actually drink the ice cream rather than eat the ice cream, right? So that one straw reminds you of a true hyphae. There is a sleeping cat for catalase positivity, and that's pretty significant. Catalase positive, right? So for CGD patients, Candida is normal flora of the GIT and oral cavity, so its presence does not mean that it's causing pathology. The crying baby in a red swing on the right depicts severe diaper rash, hence why the swing is red and the swing looks like a diaper. The old man with a cane and a boy throwing snowballs tells us that oral candidiasis can present at any age. Right, so you have this old guy up here, he looks really creepy with that weird smile, and this little kid over here, there's even women, right? Everything's in this picture, so anyone can be infected, right? You have a little girl over there, and of course we already saw the baby boy. The boy is holding a blue inhaler, right? That's his little blue inhaler right there. A blue inhaler, and not washing your mouth after using inhaled steroids can lead to oral candidiasis that can be scraped off, compared to precancerous leukoplakia, right? So everyone that uses an oral inhaler is taught to always rinse their mouth after doing so. Otherwise, they'll get oral candidiasis because the immune system, the immunity of your mouth gets weaker with that oral inhaler. The person in green on the left is scraping snow, and there is a KOH salt shake because it helps find Candida. Right, so this thing says KOH on it, but really he's just picking up snow and throwing it away or something, or moving snow. No one picks up snow and throws it away, but he's moving snow out of the way. So what he's showing you is that this can be scraped. Candida can be scraped, and it's also identified using KOH. If Candida causes esophagitis, it's most likely a patient with HIV and a CD4 count of under 100, depicted by the max 100 pounds sign and the ride next to the boy, right? So the maximum weight that this thing can sustain is 100 pounds, so this guy should probably get off of it. And this ride kind of looks like an esophagus, right? So you're seeing esophagitis. The school teacher is being hit by snowballs on her crotch to depict vaginal candidiasis, and she dropped her birth control pills, prescription pills, and a jar of candy, as seen in Pseudomonas for diabetes. Right, the jar of candy is the same jar of candy that was there in Pseudomonas. Antibiotics, birth control pills, and diabetics are predisposed to candidal vaginosis since antibiotics kill the normal vaginal flora. The pH will be normal, so below pH of 4, compared to Gardnerella, where the plants were priced at a pH of above 4.5, right? It was more basic than it's supposed to be. The 3 heart-shaped pyramid roofs are similar to the 3 pyramids from the Staph aureus because IV drug users are at risk of candidal tricuspid infection. So you have your 3 pyramid-shaped things with a heart on it. Tricuspid infection from IV drug use. Use azoles, which is again represented by the pine cones you're seeing on the tree, for general infection, including the diaper rash, and amphotericin B for immunocompromised patients with disseminated infections. So you have your frogs. Where do they put the frogs? Oh yeah, the frogs that this girl is writing on. Okay. Candidal esophagitis requires nystatin, depicted by the play nice sign for nystatin. Right, nystatin has to be given to someone who has candidal esophagitis, and you're supposed to just drink it. It's not a medication that you just swish and spit out. You're always supposed to drink it. It has to affect the whole esophagus as well, and it kills everything on the way down. All right. So normal pH, candidal vaginosis, as opposed to Gardnerella vaginitis, where you had your pH getting a little more basic, and clue cells and all of that stuff was in that picture too. Alright, so we just finished our big guy Candida. Pseudo hyphae at 20 degrees, one real hypha in 37. That's just how you want to remember it. It's not going to be one, but it just helps remember what's happening. The book itself uses images A, B, and C. So A, you're seeing the same thing we saw with the snowballs and the pseudo hyphae, whereas B, you can see it is pretty much just one hypha coming out of the ice cream. So your warm ice cream that you can drink. Right here, you're seeing the infection, pretty much candidal infection of the mouth. It's going to lead to esophagitis because that seems like it's going pretty far down this person's throat. So that's images A, B, and C for Candida. Next up is Aspergillus fumigatus. So septate hyphae that branch at 45 degrees. So Aspergillus has an acute angle, has something that was always easy to remember, 45-degree acute angle. Right, you can see that here. Like this is one right here. This one, 45-degree acute angle, right? This angle is not the one you're looking at. That would be 90 degrees. But what you're really looking at is the smaller angle that's there. The smaller angle won't be there in the other guy. We're going to see another guy where the angles are pretty important. So you have your 45-degree acute angles that are forming in all these hyphae. Right? Causes invasive aspergillosis in immunocompromised patients, neutrophil dysfunction such as CGD. So again, we're going to see catalase positivity. Can cause aspergillomas in pre-existing lung cavities, especially after TB infection, and that gets tested as well. Some species of Aspergillus produce aflatoxins, which is associated with hepatocellular carcinoma. Treatment is voriconazole or echinocandins. Right, voriconazole though, not just any other conazole, not itraconazole. You have to use voriconazole for Aspergillus fumigatus. Aspergillomas are colonization, not invasion, of a pre-existing lung cavity. And that was a dumb URL question where they were really testing you on the terminology. Like you remember, yes, aspergilloma in a pre-existing lung cavity after TB, but is it colonization or invasion? Is a really silly question to ask, but it's actually colonization. The other thing you do get questions on are ABPA, allergic bronchopulmonary aspergillosis. It's a hypersensitivity response to aspergillus growing in the lung mucus, associated with asthma and cystic fibrosis, may cause bronchiectasis and eosinophilia. Right? So invasive aspergillosis needs to be treated with prescription antifungal medication, usually voriconazole. Other antifungal medications used to treat aspergillosis include lipid amphotericin formulations, posaconazole, isovuconazole, itraconazole, caspofungin, and micofungin. But as far as your test is concerned, pick voriconazole. Or pick any other weird sounding conazole you've never heard of, but don't really go for itraconazole immediately. ABPA occurs in 10% of corticosteroid dependent asthmatics. Repeated exacerbations and intense airway inflammation produce pulmonary infiltrates. And then up here I wrote invasive aspergillosis can cause infection and infarcts involving skin, paranasal sinuses, kidneys, brain, and endocardium. It may mimic mucor mycoses presentation, but rhizopus and mucor have broad angles, and we're going to see that soon enough. Right, so acute angles in aspergillus. Right, acute angles, 45 degrees, and that's it. So let's look at the sketchy micro image for that. Right, and now I never forget voriconazole because they did make a vortex in this image, right? And there is a cat on this as well. So eventually the number of images starts getting to the point where you're like, damn, that's so many images I've memorized now. Which one was for who? So you have to do a good job to make sure you remember which image is associated to which bug, and as many of the details as possible from that image. So Aspergillus, this is asparagus farm, right? Asparagus is something you can actually grow on a farm. Asparagus farm. The fumigatus sounds like fumigate. So you see a crop duster spreading its fumes on the farm, right? So crop duster spreading its fumes on the farm. That's this guy up here. One thing we forget is that Aspergillus is catalase positive, just like Candida. So we have that cat on the scarecrow. The peanut plant on the bottom left represents aflatoxins, which is also related to peanuts. A toxin produced by Aspergillus flavus, and the toxin is associated with peanuts and wheat, hence the grain field behind the scarecrow. Right? And aflatoxins are discussed in the book as well. And you have to remember that aflatoxin can lead to hepatocellular carcinoma. So the cow has a liver spot and a tractor with the crab on it. Right? The same crab we saw when we did Helicobacter pylori. So this cow with the liver spot and this tractor behind him with the cancer crab. Right? So hepatocellular carcinoma from aflatoxins, peanut, and wheat. Alright, cool. Exams may try to trick you in your ability to compare Aspergillus from mucor. The peanut plant represents the acute angle of branching, right? All the angles in this thing up here are acute. No obtuse angles. Or no 90-degree angles either. Aspergillus, acute septations, right? Aspergillus, AS, acute septations. Aspergillus forms conidiophores with fruiting bodies. Conidiophores with fruiting bodies. And get released into the air and gets inhaled. Aspergillus can cause 3 types of infections. First, we have ABPA, represented by the worker in the middle. Right, ABPA, the worker in the middle. This is a type 1 hypersensitivity reaction with wheezing, fever, and a migratory pulmonary infiltrate. So he's migrating or running. He's running. And he is carrying an inhaler for its association with asthma as well as cystic fibrosis. Blood would show high levels of IgE. So he has his little pink inhaler, right? Then you see these two guys, right, with their bloody handkerchiefs. So the worker on the left demonstrates aspergilloma. Aspergilloma are gravity dependent, so they will be in the lower lobes. The worst is angioinvasive aspergillosis in the immunocompromised. So that's the guy on the right with his cane. Okay. And you can kind of see the cane is almost, in a way, it looks like it's digging into the frog, like it's killing it by mistake. It invades blood vessels and disseminates throughout the body, so you can see acute angled septate hyphae in the blood, represented by the red hoses under the scarecrow. Right? Acute angled septate hyphae. I don't really tend to remember the red hoses much when I see this picture in my mind. But it does invade blood and it goes everywhere. The affected organs are on the scarecrow. Right? And those are the patches that are affected. So you can see the knees are affected too. Straws on the kidney, heart, head, kidney failure, endocarditis, and ring-enhancing lesions in the brain. Right? Spread to paranasal sinuses can cause necrosis, which is also caused by mucor. Treatment is with voriconazole, hence the vortex with pine cones back here. Right? So it kind of falls into place why this guy is running. And amphotericin B in the immunocompromised. The aspergilloma must be surgically removed. And that's another thing you get a question on. You don't just let it be there. It has to be surgically taken out. And it is not an invasion, right? It's just a colonization of something that was previously formed by maybe TB, emphysema, sarcoidosis, whatever this person had earlier that left a nice spot for this to inhabit. So that's aspergillosis right there, right? Allergic bronchopulmonary aspergillosis in whatever asthma or cystic fibrosis patients, otherwise a history of TB and acute angles and voriconazole. That's all you're really trying to remember there. Cryptococcus is really high yield. I would say a little more high yield than Aspergillus. Cryptococcus neoformans, 5 to 10 micrometer with narrow budding, heavily encapsulated yeast, not dimorphic, found in soil, pigeon droppings, so just like we saw pigeon droppings for histo, acquired through inhalation with hematogenous dissemination to meninges. Now remember, histo did not cause any issues in the meninges, right? It was just palatal and tongue ulcers. The one that did cause meningitis was your coccidioids. Right, we saw with coccidioids can cause meningitis, but coccidioid, right, did not have anything to do with pigeon droppings or caves. It was more about excavations and earthquakes, as you can remember from the Presidio, coccidio, Presidio, right? So there is very obvious differences that you have to use to kind of be able to differentiate what's the correct answer. So found in soil and pigeon droppings, acquired through inhalation with hematogenous dissemination to meninges. Highlighted with India ink, you're going to see a clear halo such as the one you see over here. India ink right here. And mucicarmine, red inner capsule, mucicarmine. So both of these are two different kinds of images you can get for your Cryptococcus neoformans infections. Alright, so let's just keep it like that. So you can see both different images right here. Now, latex agglutination detects polysaccharide capsular antigen and is more sensitive and specific. So that's the one you really want to do, the latex agglutination test. And what's annoying, I remember this even now, is when I was studying for step 1, it was always annoying because you wish they would just, if they're ever talking about Cryptococcus, they would just give you this image G, or just talk about India ink, and it's like, a giveaway. But then you talk about mucicarmine or latex agglutination, and all of that has to ring a bell for Cryptococcus. So if you're new to studying for this, it's going to be something difficult that'll take time for you to master, because for me, it was definitely a thing. Like, I would get questions wrong because they mentioned mucicarmine, and I forgot that mucicarmine was the other thing that I could use to stain Cryptococcus, right? Or that latex agglutination works because they have a polysaccharide capsule, which is pretty significant because it is not dimorphic, and it's not dimorphic because it's heavily encapsulated, so it doesn't really need to change its form to survive in different environments, right? Causes cryptococcosis, cryptococcal meningitis, cryptococcal encephalitis with soap bubble lesions in the brain, and it'll generally just affect immunocompromised people. Now the soap bubble lesions are pretty cool, right? Because you can see how this resembles bubbles, right? It's all over the place, and there's no real form of distribution, right? So let's look at, and then treatment, amphotericin B and flucytosine. Flucytosine is a big deal. Amphotericin B and flucytosine followed by fluconazole for the cryptococcal meningitis. If they don't have the cryptococcal meningitis, you still give them fluconazole just in case it's still in their meninges and hasn't caused the meningitis yet. So you still have to give them everything. So let's take a look at that sketchy micros. This one, another great image. I've always remembered most of the stuff of crypto from this image. So now you're in a crypt for Cryptococcus, right? Like inside a pyramid. So you're in a crypt. The scene is in an Egyptian crypt, and we have an archaeologist who is cleaning and inspecting the crypts. We have two sarcophagi, which represent the crypto is encapsulated heavily, right? So the sarcophagus itself, the heavy encapsulation is perfectly memorized by, alright. The repeating pattern of circles on the left sarcophagus is for the repeating polysaccharide antigen in the capsule, which is the main virulence factor since it makes it antiphagocytic, right? So this is the polysaccharide on the capsule. That's what they're showing you over here. So that's perfect. Right away, you see two sarcophagi inside this crypt, and you remember Cryptococcus is encapsulated, and the sarcophagus is heavily encapsulated. It is often found in soil and pigeon droppings, and once it is inhaled, it settles in the lungs and may disseminate. Hence the several pigeons and their droppings, right? There's poop all over the place, and he's here to clean up, so it falls into place. Mad pigeons flying around, poop all over the place. Perfect. He's here to clean up. The primary focus is in the lungs, so the guy is coughing. His spray bottle represents urease positivity, right? Urease positive. It's not catalase positive. There's no cat in here because you have a bunch of pigeons, but it is urease positive, which also falls into place perfectly because he's here to clean. So you're going to use your urease soap that we've been using throughout Sketchy Micro. The left mummy, this one over here, depicts immunocompromised, so he has a cane. This is associated with HIV patients. Pulmonary symptoms can be asymptomatic but may cause cough, dyspnea, and other lung infections. It can spread to the CSF and cause meningitis. The number one cause of fungal meningitis is Cryptococcus. So he's wearing a neck brace. Right? So this guy himself is wearing a neck brace. So that's the meningitis part. Number one cause of fungal meningitis. I should make that red. This text is always red in the book. Number one causes are pretty important things to remember. Alright, so he's wearing a neck brace. It can lead to permanent neurodeficits. So fever, pneumonia, meningitis, so far we're good to go with this guy. right? Culturing is done on Sabaraz agar, the same as for all fungi, but it takes a week to come back, so it's going to be really slow, and they don't even really mention it much in the book. I mean, they mention Sabaraz agar, but they don't keep mentioning it, and they don't mention it with each bug either. So Sabaraz agar is already one thing, but we saw already many different things you could use for crypto. So instead, bronchopulmonary lavage of lung tissue depicted by the soap bubbles on the chest and chest can be colored red or silver via red mucicarmine or silver methenamine. Another little thing that wasn't really mentioned there, silver methenamine, right? We only saw the mucicarmine and the latex agglutination and the India ink. You can also use silver methenamine. A negative stain. The India ink is a negative stain. CSF gets stained with India ink, which is a negative stain that stains the background and leaves the crypto with halos, depicted by the pot at the far right, having dark background, and you can see the things in there that look like eggs. The better diagnostic test is the latex agglutination test that detects the polysaccharide capsular antigen and causes agglutination, depicted by the latex gloves near the patterns, and that's what he's basically wearing. He's wearing latex gloves near the patterns for latex agglutination of the capsule. Crypto can cause soap bubble lesions in the gray matter of the brain, hence the bubbles on the mummy's head. Treatment is laborious. Patients need joint therapy of amphotericin B and flucytosine together, followed by fluconazole. So we see frogs, pine cones, and paintings playing a flute for both flu medications, right? So you have your cone, the frogs, and this flute to remind you of flucytosine and fluconazole. Not so bad. So the main thing is there's a lot of stains, right? Different stains that they can give you. So they mentioned India ink, mucicarmine, right? Then in Sketchy Micro, they mentioned the silver stain, silver methenamine. So there's a lot of staining involved. Narrow budding means there is a pinched stalk between the mother and the daughter, right? Narrow budding. Narrow budding would be the opposite of broad-based budding, right? So a very thin stalk between the two cells that are about to separate. Right, so that's all the Cryptococcus stuff. The last thing on this page are mucor and rhizopus. They are irregular, broad, non-septate hyphae branching at wide angles, so over 90 degrees. And you can see that in this image right here. Right now, I don't agree. Why is it this image? This is not a wide angle. This is actually pretty acute. I have a better image up here. Right up here, you can see these are pretty acute angles, right? These are acute angles. Here they have bigger angles. The black line is kind of showing you the angles that you're seeing, right? So mucor and rhizopus have similar clinical presentation to invasive aspergillosis. Differentiation is usually only possible by a micrograph. The left one shows mucor with its 90-degree angle, right? So bigger angles, 90-degree angles, and lack of septation. It's not septated, right? There's no septation happening. While Aspergillus on the right has V-shaped acute angles and is septated. Right? And this is septated. You can see septations happening in between. Many septations, it's got many septations to it. But the acute angles are more visible. So when they tell you here to differentiate between D and I, it's not that obvious in this first aid book, in my opinion, at least, right? Like over here, I can definitely see the V acute angles very evidently. The V acute angle, another V acute angle, but this also looks like a pretty acute V angle. It's not that big, right? So I wouldn't say it's a good image, in my opinion, but it is what it is. That's what you get to work with. This image I put here, this is showing you Cryptococcus, right, with the silver methenamine stain. Right, this is what the silver methenamine stain looks like. So it's very important to remember all the stains, right? G, H, and I, and then latex agglutination. So here you can kind of see the narrow budding, right? You see how thin that stalk is between these two guys? Really thin stalk between these two guys, as opposed to broad-based budding where there's going to be a broad area between the two cells that are separating. So that's a silver methenamine stain you could use for Cryptococcus. Alright, so mucor rhizopus, wide angles, causes mucormycosis, mostly in ketoacidotic, diabetic, and or neutropenic patients, someone who's got leukemia. Inhalation of spores leads to fungi proliferating in the blood vessel walls, penetrating the cribriform plate, right, and entering the brain, and that's just really bad. rhinocerebral frontal lobe abscess, cavernous sinus thrombosis, headache, facial pain, and black necrotic eschar on the face may have cranial nerve involvement. And these patients often just die. Right, so that's the worst part. Once it enters the cribriform plate, there really isn't much you can do. So it's a really difficult one to treat. And where's the? Let me see. Sketchy had a pretty good image for that. Interesting. Where did I move it to? Because I believe it was like a waterfall or something. Huh. Oh no, that's Naegleria fowleri. That's the one that's rapidly fatal. Okay. And I believe this one also enters from the cribriform plate. Yeah, enters via cribriform plate. So I was confusing the two. So right here, mucor and rhizopus, they do enter the cribriform plate, but they don't. This one won't kill you. This one doesn't kill you. It has bigger angles, but it doesn't necessarily kill you. It just causes abscesses, right? And you can see the list of things it'll cause: black necrotic eschar on the face, some cranial nerve involvement, which can obviously give you a whole array of different symptoms. But don't confuse it like I just did right now, because I'm definitely out of practice for this. But don't confuse it with Naegleria fowleri, which is waterfall. Right, this is your waterfall right here, where the people die. People die because once this enters the cribriform plate, it just kills you. Amoebas and CSF, and it's just really bad. Amphotericin B is the only treatment. We'll get to that when we get there later. But mucor rhizopus is just fungal. It'll just cause a bunch of fungal level issues. So the black necrotic eschar and your abscesses and thrombosis and stuff, facial pain, facial nerve involvement, trigeminal nerve involvement, watch out for that. But other than that, surgical debridement and amphotericin B or isavuconazole, right? And they love playing with these medications on step one. Like, they'll throw you all these different conazole medications, and you're like, wow, I thought all conazoles were the same thing. They're not, right? Itraconazole is a pretty common medication for a lot of them. In crypto, we saw you have to give fluconazole after AMP B and flucytosine. We saw voriconazole for Aspergillus, right, because the vortex. Here you have isavuconazole. I used to think of this as isovuconazole. Iso to remind me of mucor and rhizopus being the same thing. Iso means equal in a sense, right? So isovuconazole to remind you of isavuconazole. That worked for me just fine. Obviously, I didn't remember this just now, but as I'm studying it again, it's coming back to me that I did do that when I was studying for my step one. So isovuconazole, amphotericin B and isovuconazole, because you don't want to give amphotericin B to everyone. When we get to the medications at the very end, antimicrobials and stuff, you're going to see amphotericin B is a really bad medication with a lot of really bad side effects. So you don't want to mess around with that medication. And if the person is not doing so well to begin with, you don't just go ahead and give them amphotericin B anyway. One special thing about mucor and rhizopus, though, was the ketoacidosis thing. Right, you get questions on diabetic ketoacidosis all the time. Now, if you can combine that with mucor and rhizopus microbiology, that just makes it another really good question for step one people. So let's take a look at this one. A 30-year-old man is admitted to the intensive care unit, the ICU, after his wife found him unconscious at home. She says that he has lost significant weight for no reason. Lab studies show a serum pH of 7.1 and positive serum ketones. Okay. Mucous membranes are extremely dry. Treatment is initiated and the patient's condition improves. So at this point, you already know he has diabetic ketoacidosis. However, he now has fever, headache, and eye pain. Examination of the nasal cavities shows a black necrotic eschar adherent to the inferior turbinate. So in his nose, he has a black necrotic eschar. Which procedure would reveal the pathogen responsible for the fever, facial pain, and eschar. And you would have to do a mucosal biopsy. That's about it. But when you see that black necrotic eschar and diabetic ketoacidosis, you're supposed to remember mucor and rhizopus. These symptoms in a patient with likely diabetic ketoacidosis, right, low pH, ketones, dry membranes, young with unintended weight loss, these features are highly suggestive of mucormycosis caused by mucor or rhizopus. And they're both the same, so you would just give this person isovuconazole. Right, that's the easy way to remember that. The increased incidence of mucormycosis in diabetics is due to the ketone reductase activity of rhizopus. Right, a little key thing that you can get a stupid, annoying question on. right? Rhizopus apparently has ketone reductase, so it's able to use ketone bodies very well. And diabetic ketoacidosis is very different from general ketoacidosis that a non-diabetic person does, right? Diabetic ketoacidosis is nearly fatal, and you can die from it. Whereas when I'm in ketoacidosis, because I'm actually dieting like that, that's not the same thing. Right? So I'm not at increased risk of mucormycosis, but a diabetic person who's having ketoacidosis, that person is at risk of mucormycosis. And it's very important for me to stress this because I have gotten messages from people where they were asking about the keto diet, and at least a handful of them were confused about how the keto diet would be an okay thing to do when it's so dangerous, apparently, because they were thinking of diabetic ketoacidosis, or that's what most of them thought of when they thought of keto, not the actual keto diet and what is ketosis, not ketoacidosis. Two different things, right? So that's all your opportunistic guys, and well, actually, there's more. Those are all your opportunistic fungal infections from that page. Another really high yield, popular one is Pneumocystis jirovecii, where almost anytime you ever see PCP in a question, you know this is an AIDS patient, right? Like, that's the first thing you want to think of and confirm, is this an AIDS patient? Causes pneumocystis pneumonia, PCP, a diffuse interstitial pneumonia, yeast-like fungus, originally classified as a protozoan, which is not something you really need to know. This is a dumb statement, but it's a yeast-like fungus. Most infections are asymptomatic. Immunosuppression, such as in AIDS, predisposes to disease. Diffuse bilateral ground glass opacities on chest imaging with pneumatoceles. Right? Pneumatoceles are what you're seeing in image B. Right? This is such a messed up view, right? It's very similar to something you would see in cystic fibrosis patients as well. We had a similar x-ray like this when we looked at the cystic fibrosis patients way earlier in biochemistry. And ground glass appearance of both lungs. Like, the whole lung has ground glass appearance. Ground glass appearance is what's happening right here, this kind of thing. If you don't know what ground glass looks like, you should Google it. It's a very, actually, let me just do you guys a favor, because I've had many students that did not know what is ground glass, right? And I used to have a chess set made of ground glass, so I would literally show people, like, that chess set, and you would know. So now, when I searched for ground glass, right, most of my things that showed up were all x-rays, because I'm always searching. This is ground glass, though, this thing. So I'm sure most of you guys at some point definitely have had experience with ground glass. So you can see how it's different from glass, where glass is very see-through. Ground glass, not so much, right? Very hazy, very powerful material. Alright, so I had a chess set a long time ago that was all ground glass. And a couple of those pieces broke from falling, so I had to get rid of it. But that's ground glass. So you can see how that is ground glass right here. This is all ground glass right here. I'm not sure what's causing these black lines in this area right here. I'm not sure what that's about. But basically, both lungs will be full of ground glass appearance diffusely. But you don't see any pleural effusion. Nothing's filling in these corners. No pleural effusion. No inflammation of that type. And they would tell you enough information in that question. The other very direct thing is CD4 count below 200. That's when you have to start prophylactic treatment. Prophylactic treatment for AIDS patients, HIV patients, is a big deal, right? You have to memorize all the different prophylactic treatments and when you're supposed to start them. And when you start the prophylactic treatment for PCP is at a CD4 count under 200 in HIV patients. Other than that, treatment is with trimethoprim sulfamethoxazole, pentamidine, another medication that's very rare, but it can come up in your answer choices. Dapsone, which we saw when we were doing leprosy, right? Prophylaxis as single agent or treatment in combination with trimethoprim, and atovaquone. Okay, so atovaquone and pentamidine are ones I never really tend to remember for PCP. So if you can, then definitely do. This last image is the one that they usually give you in UWorld. Definitely, they give it to you a couple times. Disc-shaped yeast seen on methenamine silver stain of lung tissue. Right, so methenamine silver stain always looks like this color, and I showed you what it looks like for Cryptococcus earlier. Right? Cryptococcus had budding happening in it. Here we're seeing disc-shaped yeast. Right, so dapsone, pentamidine, atovaquone, trimethoprim, Prophylactic treatment for PCP is dapsone, so there's that. Sporotrichs schenki, also I've seen questions in New World from it. Sporotrichosis, pretty easy thing to figure out. Dimorphic, cigar-shaped budding yeast that grows in branching hyphae with rosettes of conidia, and it lives on vegetation. When spores are traumatically introduced into the skin, typically by a thorn, hence why it's called rose gardener's disease, it can cause local pustular ulcer with nodules along the draining lymphatics. So that's why you see what you see in this patient. Right? Ascending lymphangitis, disseminated disease possible in immunocompromised hosts. Treatment is itraconazole or potassium iodide, but the potassium iodide is only for the cutaneous or lymphocutaneous stuff, right? But itraconazole is for the systemic aspect. Think of a rose gardener who smokes a cigar and pot. Pot is weed. That's the street name for it. Biopsy of the lesion typically reveals a granuloma consisting of histiocytes, multinucleated giant cells, and neutrophils, surrounded by plasma cells. From the site of inoculation, the fungus spreads along lymphatics like ascending vines, forming subcutaneous nodules and ulcers. Then we have a bunch of images down here. So Sporotrichs schenki, growing on Sabouraud agar, right here. This is Sabouraud agar growing Sporotrichs schenki. Micrograph of schenki conidia stained with lactophenol cotton blue. So this is schenki again. And then a phase contrast microscopy of yeast form right here, which also kind of reminds you of the Candida yeast form. Right. This is a question from Amboss with this image. Right. So it's a very low magnification image right here. But when you see an image like this, a histological image like this, you should know that they're showing you silver methenamine. Right. So you can already cut down how many things can you actually stain with silver methenamine. So far, we've only talked about crypto and PCP, Pneumocystis jirovecii. So a 33-year-old man with HIV comes to the physician because of non-productive cough and shortness of breath for 3 weeks. You can stop right there and look at the histo image, which you've already kind of saw with your peripheral vision when you did the question, and already start thinking of Pneumocystis jirovecii and make sure that you pick the correct answer. And if you're looking at the answers, and if you're running out of time and you look at the answer choices and the question is just microscopic examination will show you what, well, you already know silver staining, disc-shaped cyst, and you're done. Because this is Pneumocystis jirovecii, right? But then they do go on to tell you a lot of stuff about his HIV. They even give you the CD4 count is below 200. It's 176, right? He doesn't have Legionella, which is just there to throw you off, I guess. Because a lot of people will remember silver stain can be used for Legionella, but this is not Legionella. Remember, Legionella causes pneumonia in patients who have emphysema or they smoke excessively, and that's not what we're getting here. Alright, so very good differential. Very simple, straightforward question, but not many people got it right, which is why I put it here. A lot of people forget the silver staining of Pneumocystis jirovecii shows you disc-shaped things. And this is very low magnification. So you know that they're definitely not trying to get you to see any budding. So you're not going to pick Cryptococcus. They're not showing you budding. No reason for you to pick Cryptococcus. They didn't give you any Cryptococcus type of information in the question either. And then we have a bunch of more questions, all coming from UWorld, regarding the things we just looked at. So let's wrap it up with that. So, first one, 21-year-old previously healthy man comes to the office due to fever, malaise, myalgia, and non-productive cough. I don't have a cardio rapid one, do I? I don't think I have a rapid video. So, I'm actually very proficient at the cardiology stuff. It's going to be a while until I get to cardiovascular because I still have to go through viruses, systems, path, farm, and then the first one is cardio. But the cardiovascular videos I have up right now are in-depth videos, and they're good. Oh, okay, yeah, the 30-day review, that's pretty in-depth. That's in-depth. I get, yeah, the 30-day review one. Do those. Do the 30-day review videos. They are in-depth. They're not going that quickly. I do go into most of the stuff pretty well. And if you feel like it's going too fast, then do the original cardiovascular playlist I have. That playlist is also very in-depth. It's complete. It's not missing anything. Has all the pictures, all the UWorld questions. It's really important to understand cardiovascular physiology the best you can. which includes understanding ECGs, and includes understanding the nodes, right, and how they work, the AV node versus the Purkinje fibers and all of that. You have to know that very, very well in depth. Otherwise, you're gonna be very confused when you get the questions. And then cardiovascular is also very hard because of the graphs you have. So I think in the 30-day one, I went pretty in depth in all the graphs and everything. But just in case I didn't, no, I did. You should do the 30-day one. Do the 30-day one. And if you don't like it, if you feel like it's too quick or if it's missing something, then do the original cardiovascular playlist, which was done almost a year ago now. But it was complete. Cardiovascular was the first thing I ever completed, and it wasn't missing anything. The only thing those videos will be missing are AMBOSS questions, which I have now. All right, so that's good enough. Best of luck. I really hope it helps out to you. All right, so now continuing back to your questions, all the questions regarding all the mycology stuff we covered today. So first one, 21-year-old previously healthy man comes to the office due to fever, malaise, myalgia, and non-productive cough. Alright, his symptoms began 2 weeks after returning from exploring caves in Missouri. So as soon as you see exploring caves, you should think of histoplasma, right? Because remember, histo doesn't just hide in macrophages. Histo hides in macrophages and histo hides in caves. Okay, so that's another way to remember that aspect. And all histoplasto, coccidio, they all cause pneumonia anyway, so we haven't seen anything specific yet. The patient does not use tobacco, alcohol, or drugs. Temperature is high. Blood pressure is normal. Pulse and respiratory rate are okay. Physical exam reveals lung crackles. Chest x-ray shows patchy parenchymal infiltrates with enlarged mediastinal and hilar lymph nodes, so that's all pretty normal from getting histo or blasto. What is most likely to be present in his pulmonary lesions? And you would pick the answer that's related to histo because they mentioned caves. Like that's literally all it took. This question didn't give you anything specific to pick on histo besides the caves and Missouri, and that was enough. So you would pick macrophages with intracellular small yeast. Histoplasma capsulatum is a dimorphic fungus endemic to the Ohio and Mississippi River valleys and exists as filamentous mold in the cold, right, in the environment, and is found primarily in soil contaminated with bird or bat droppings. Thus, infected patients often report a history of exploring caves or cleaning bird cages. It is inhaled, phagocytosed by alveolar macrophages, and then escapes lysosomal destruction and spreads to the hilar and mediastinal lymph nodes and is controlled by cell-mediated immune response, which forms granulomas. Very similar to the cell-mediated immune response you would give to the other guy that hides in macrophages, which is your big guy TB, M. tuberculosis, right? So that's the first question right there. Histo is always going to be a very easy question. Next one is about blasto. So you see a 49-year-old man comes to the office due to 4 months of cough and weight loss. His medical history is otherwise unremarkable and he takes no medications. He's a farmer in Mississippi. He does not use tobacco, alcohol, or drugs. Temperature is high. Exam shows right lobe crackles. Chest x-ray reveals pulmonary infiltrate in the right upper lobe. Bronchoscopy shows granulomatous inflammation, and he does not have HIV. So since he doesn't have HIV, he's not going to have all the other systemic manifestations of blastomyces, right? We saw when we did blasto, there was blasto skin too. Remember that? So let me show you the picture. Like this, right? And that's not going to happen to him. See, I just told you histo hides in caves, right? Histo hides in caves also. Blasto blasts the skin. So that's the other thing you have to remember, right? This, the squamous cell carcinoma of the skin. Coccidioid was this image about the presidio, right? So as long as you can remember the presidio, you'll just remember earthquakes or dust from anything, and you'll get the coccidioid question correct as well. But blasto blasts the skin, and he's not going to have blasting of his skin because he's not immunocompromised. But all they gave you in that question was pneumonia kind of thing happening and Mississippi. And the Mississippi was the giveaway that he has blastomyces. Next one is a 48-year-old. This is also blastomyces. This is a 48-year-old man, comes to physician with 6-month history of cough and fatigue. He also has malaise and weight loss, does not recall any sick contacts, is a carpenter, smokes 1 pack of cigars daily, temperature is fine, exam shows left lower lobe crackles, does not have HIV, chest x-ray reveals a pulmonary infiltrate in the lower lobe of the left lung. Results from sputum KOH prep are shown in the image And I don't have the image here, but the image showed you broad-based budding, right? So if you see broad-based budding in an image that's given to you, and all you see is a question about a non-HIV patient with symptoms that look like TB, you pick blasto and you call it a day, because blasto buds broadly, and that was it. 45-year-old man, this one is coccidioid now. 45-year-old man comes to the urgent care clinic because of fever, severe headache, myalgia, and pleuritic chest pain. He has had these symptoms for several days. Physical exam shows fever and mild tachycardia. Lung auscultation reveals mild crackles. Radiographic exam is consistent with segmental pulmonary infiltrates. The patient fails to respond to empiric antibacterial antibiotic therapy, so it's not a bacterial infection. Microscopic exam of the lung tissue obtained from him shows spherules packed with endospores. Spherules packed with endospores. Alright. His history is most likely to reveal what? And the answer was recent travel to Arizona, which is in southwest America. Coccidioides immitis is a dimorphic fungus that has a mold form of hyphae at 25 degrees Celsius and an endospore form of spherules containing endospores at body temperature of 37. It is endemic to California, Arizona, New Mexico, and western Texas, as well as northern Mexico. Right, so that's that southwest U.S. area. But they didn't give you the area. They gave you the fact that you see endospores, and that is only coccidioids. Coccidioids is the only one that has all those endospores inside of a cell, and they're much bigger than red blood cells are. All right, next guy is going to be blasto again. So a 54-year-old man is brought to the emergency department due to a week of progressive headache and confusion. He was treated for viral esophagitis 6 months ago and pneumocystis pneumonia 2 months ago. So you already know he's going to have HIV, right? This has to be an HIV patient if he has viral esophagitis. Doesn't happen to you and me. It's not something that's going to happen to immunocompetent people. And pneumocystis pneumonia. He's lethargic and oriented to person and place only. CT scan of the head shows a mildly decreased CT scan of the head shows a mildly increased ventricle size but no other abnormalities, so he has ventriculomegaly. Lumbar puncture reveals an elevated opening pressure, and CSF analysis shows moderately increased protein and pleocytosis. Latex agglutination is positive for soluble polysaccharide antigen. Ooh, okay. So it's not. This isn't blasto. Once you hear latex agglutination, you already know what that's supposed to be. That's going to be your crypt guy. Right? This could have been any other stain as well. It could have been India ink. It could have been silver methenamine, and latex agglutination. What was the other thing? Mucicarmine. Right? So light microscopy will reveal what, and you're gonna see budding yeast. But this is gonna be budding yeast that is not broad-based budding, and it's gonna look very different. This patient's opportunistic infection raises suspicion for untreated AIDS. He is now presenting with symptoms of cryptococcal meningitis, and the latest agglutination test confirms that. The yeast can obstruct CSF outflow, so most patients have an elevated opening pressure on lumbar puncture, and he had the ventriculomegaly from the same exact reason as well. Right, so that was your little question on crypto, and this last sentence could have been anything. It could have been latex agglutination, mucicarmine, silver methenamine, India ink. Any one of those stains, and you would know, and you would have to know that it's Cryptococcus. Alright. Next one here, Aspergillus. So you have your 47-year-old man comes to his primary care physician with persistent night sweats and fatigue. A thorough evaluation yields a diagnosis of chronic myeloid leukemia, CML. While undergoing treatment for his malignancy, the patient comes to the oncologist complaining of headaches, scant nasal discharge, and a problem with his left eye. Physical exam reveals tenderness over the paranasal sinuses in addition to left-sided orbital swelling and cellulitis. Mild proptosis of the left eye are also present. Biopsy of his sinus mucosa is shown in a very unique micrograph that's full of bright red dots and purple hyphae that are segmented and branching at acute angles. So I didn't put the image here, but that's what you were supposed to catch in that image. What is the cause of his condition? And you would pick Aspergillus. 35% of the people got Aspergillus. 45% chose Rhizopus. And I believe it was this image that I have up here. Yeah, this one right here. Right, so if they gave, they didn't give both. They gave one image. They gave this one, right? And you were supposed to know it's going to be. Once you see this, you're going to know it's going to be Aspergillus. The septation is one giveaway, and then the acute angles is the other giveaway. right? Whereas not acute angles, right? These are not acute angles, would be mucor and rhizopus, right? And no septations, in mucor and rhizopus. So it's a very I would say it's a pretty obvious difference between all of them, between the three of these guys, well, between the two groups of these guys, but easy to mess that up if you haven't studied it enough. All right, so Aspergillus acute angles. Last one here for coccidioids once again. 52-year-old man comes to the physician because of a 4-day history of a productive cough, shortness of breath, and low-grade fever. He works as a farmer in southern Arizona. Physical exam shows multiple skin lesions with a dark blue center, pale intermediate zone, and red peripheral rim on the upper and lower extremities. There are diffuse crackles on the left side of the chest. An X-ray of the chest shows left basilar consolidation and left hilar lymphadenopathy. A photomicrograph of the tissue obtained from a biopsy of the lung is shown. Which of the following is the most likely causal pathogen? And the image below is the one they gave. This is, I believe this is from AMBOSS, so it's highlighted yellow to show you what they're trying to get you to see. Okay, so yeah, it's highlighted yellow for you to be able to know what you're supposed to see, which is this area right here. If I remove the yellow highlight, you'd be able to see the image better, which is it's just full of endospores. So the answer was Coccidioides immitis. Coccidioides is a fungus endemic to southwestern America. So again, he went to Arizona. The condition typically manifests with flu-like illness, pneumonia, and skin lesions like erythema multiforme, right? The desert rash, and then desert bumps, and we even had desert arthralgias, right? So that would be another thing he could possibly have. In immunocompetent individuals, as seen in this case, C. immitis can cause disseminated disease in immunocompromised patients, where you would have the other list of things, right? So this is the picture right here. Coccidioides image for the 52-year-old patient above. You can see a thick-walled spherule in the center of an inflammatory granuloma. The spherule contains multiple endospores, which is the giveaway for coccidioids. Right, so if I make the picture a little bigger, then you can see this is the spherule inside this granuloma, and it has a lot of white dots that you can see right now. Those are the endospores. So that would be the giveaway for coccidioid. And that's it for mycology, right? So very easy stuff. Like, compared to bacteria and viruses, it's significantly more easy. Treatment is the only thing that was new here now, right? So you have your voriconazole, isoconazole. Those are the two special ones. Fluconazole pretty much works everywhere. You have to do your best to memorize that, understand it, understand the different states, understand different history. A lot of overlap, but very good specific things that happen to people that you can use to get rid of the overlap. Alright, so yeah, good luck with that, and then in the next video I'll dive into parasites.